All right, thank you very much. I'm honored to be here, first of all. I'm waiting for people to come in still. The topic, simplifying pain education. Now, there's no question that pain education is valuable, and that's what this whole summit is about. But how does a busy clinician do it? Just so you know a little bit of my background. I went to University of Toronto, and when I graduated, I did every manual therapy course I could do. I became a fellow of the Canadian Academy of Manipulative Therapists in Canada. I devoted 10 years of my life on feeling L4-5 left rotation hypomobility. And after 10 years, I realized it was bullshit. But it took a long time for me to accept it and to go through the research studies. And then I devoted 10 years at least when I was in Australia, where I did a clinical master's program there. Paul Hodges was there, Peter O'Sullivan, the ultimate gurus. I spent 10 years devoting how to isolate transversus abdominis and left multifidus firing. And after that, I realized maybe it wasn't as effective as I thought it would be, still going by research studies. And another 10 years I've been devoting following people like Lorimer Moseley and David Butler and the rest of the people, and realized, yeah, the brain is where it's at. And I don't see the brain going out of fad anytime soon. But here's what I've learned, is when learn something new, and we don't go from being wrong to being right. We go from being wrong to less wrong. So I like to think that as we come to these summits, we just become less wrong. And I can only hope for the future, our wrongness will decrease in time. So now let's begin. Systematic reviews based on high-quality RCTs conclude that pain education is effective for chronic musculoskeletal disorders in reducing pain and improving function. Now, for every one of these references, I'm not going to be quoting references left, right, and center because that's not what I want this talk to be. My talk is meant to be a practical application, as if every one of you was a patient. And I need your full participation. So the booklet that I have in front of you, take that booklet right now. And what I'd like you to do, I'm going to give you exactly 1 minute to read the first 3 pages of the booklet before you do the questionnaire. Remember, my goal is to give pain education in 15 minutes to a patient. Go ahead and make him not be offended. Page number 2, you're starting from. You're going to read page 2, 3, 4. That's all I want you to read. Everyone reads at different speeds, I know. All right, I'm going to stop you guys. You'll get to read it later on. So which educational material is the best? We've got to explain pain, which is quite a lot of great studies based on this book. Lorimer Moseley, David Butler, the most influential people in pain education. I need a show of hands. Who here has actually read the entire book from beginning to end? Good. The majority of you. Wonderful. Now, the challenge I have is I've had trouble getting majority of my patients to begin reading it. It's deep. It's got NMDA receptors, substance P, and calcium channels and stuff like that. And it takes a few hours. Now, the recommendation how much time we should spend on pain education varies. We've got everything from 10 weeks, 1-hour sessions to 5 weeks, 15-minute sessions. So we don't really have a timeline. But all I know is this is excellent, but it takes a long time. Why do I hurt? Adrian Lowe. I want to know how many of you have read that? Good. You guys are all like, you realize in an average clinician population, that many hands would not go up. And then I'm curious about, I wrote this book so it could be read in 20 minutes. And it's written at a grade 3 level. So it's a very easy reading. It's not compared to either of those two. It's nothing, that I compare it to. So who has read The Pain Truth? I'm just curious of the show of hands. All right, it's a simpler version. Painful Yarns, Lorimer Moseley, excellent book. Avoiding the Internet, that's not a good pain education session, except the websites that we've recommended. This is Greg Lehman's book stuff. So the question is, how much time do I have? Now, you can devote as much time as you want to any of this stuff, but again, as a busy clinician, I want to see if the patient's appropriate for pain education in the first place. Here's the challenge. I don't think it's appropriate to give pain education if you don't have therapeutic alliance with them. Meaning, on the first day, if you haven't built a connection and you give them this stuff, you're going to lose them. The chances are high they're going to say, you're an idiot, I don't trust you as a clinician, I'm going to go seek care from somebody else. It may take 2 sessions before you have therapeutic alliance, it may take 3, or you never make a connection with them to say, yeah, they trust what you're telling them. So the analogy I like to give, it's called an apothecary scale. Now, the book that David Butler and Lorimer Moseley wrote is called The Dims and Sims. I just like to say, well, they talk about this. I wrote about this before they did. So I didn't steal it from them, but I give them full credit, though. So they're far more popular than I am. I just want to say, in case there's an overlap, it's because, yeah, so this is the apothecary scale. To keep you alive, your brain is subconsciously and constantly judging if you're in safety or in danger by calculating how much physical and emotional pressure or stress you're experiencing. So I tell my patients that, and I literally read them that one sentence. I went the wrong way. If the scale tips more towards the danger side, the brain and the nervous system become more hypervigilant and sensitive to pain. They seem to understand that or accept that. And if the scale tips towards the safety side, the brain and the nervous system calm down, remain relaxed, and become less sensitive to pain. Yeah, they understand that. If you're more relaxed, you have less pain. When the scale favors the safety side, the brain produces powerful chemicals that help reduce pain, such as morphine and serotonin. That's about the extent of my pain physiology education. They understand that morphine's good, and everyone pretty much knows the brain produces its own morphine. However, when the scale leans towards the danger side, the brain stops producing these powerful chemicals. Now the question is, what makes the scale tip more towards that way? So what we're going to go through right now for the next 10 minutes, we're going to go through the questionnaire, which is in your booklet, right? You're there, page number, whatever it is, 5. We're going to go through one question at a time, and I'm going to go through, and you're going to do this in real life. Now, if you have no pain, no discomfort, no functional thing, answer it as accurately as you can. All right? No one's going to read your book. No one, you can throw the book away, but I need your full participation. So you're going to circle the number that best accurately represents your D score. There's 20 questions, 10 for D, 10 for S. No, don't do it yet. First question is about pain stress. Here are the facts. The association between post-traumatic stress disorder, PTSD, and pain intensity was mediated by pain catastrophizing, fear of movement. Now, I can go through, hundreds of studies associating pain. The higher pain stress is, the more pain you have. An extreme case being PTSD. So what I'd like you to do is go ahead, answer that question right now. Circle the number. Read the description first before circling it. If you have 0, circle 0. If it's 9, circle 9. In real life. You did it? Good. Because read the description first. Good. Next one. Work stress. No, don't do it yet. I just want to take a break from doing the questionnaire. Here are the facts. Work stress is a predictor of chronic pain. The effect is stronger in men than in women. Physical exercise does not substantially reduce the risk among persons with frequent exposure to work stress. That means if you have work stress, it doesn't matter how much you exercise. It's not going to get rid of it. You're still at risk of having chronic pain. So again, I'm quoting one study, but there's so many studies on this. Go ahead, mark your work stress. Circle the number that most accurately determines you. One at a time. Good. We're done. When you're done, just nod so you've done it, so I know how fast to go. Good, good. Family stress. Greater family stress was positively related to children's pain-related expressions and distress and passive coping. And I know we had a talk about, kids having chronic pain also. So, the article is maladaptive coping and depressive symptoms, partially explained by association between family stress, pain-related distress. Being involved in a family stress causes more chronicity and pain and higher pain levels. Mark that in your own life, family stress. Put 0, put 1, put 9. Good. Next, social stress, loneliness. Chronic and transitory loneliness were associated with higher daily pain levels. Loneliness enhances risk of the pain. Mark your level of loneliness or social thing. Now, I do want to say before we go on, look up, don't circle anything else. I'm a clinician. I'm not a researcher. I'm not a scientist in any shape of your imagination. The only reason I made that questionnaire was so I understand more about my patients. This is not meant to be a validated outcome measure in any shape or form. I don't have a study on reliability or validity of it. It's just think of it as a medical intake questionnaire. But I don't give it on day one. Like somebody with a sprained ankle, I don't give him this questionnaire. But somebody coming to me with 5 years of fibromyalgia, I would. All right, so I pick and choose who I give this to because then the questions become relevant. Next one, financial stress. There's an association between socioeconomic status and prevalence of severe pain, which is even stronger with sickness, absence due to pain. Now, we have so many studies. Socioeconomic stress is a predictor of chronicity. Go ahead, mark that. Circle that one. Question 5. Good. None of these stresses on their own make you 100% that you're going to have chronic pain. That just doesn't happen. But when things pile up, that's when the whole cup analogy. Insurance, legal stress. Work-related litigation for chronic pain was strongly associated with higher levels of pain-related disability. I'm just quoting one study. So go ahead, mark that, legal stress. If you're involved in any legal litigation, workman's compensation, car insurance. Now, I'm from Ontario, and in Ontario, in Canada, we have a no-fault policy. So there's no such thing as, suing after you're in a car accident. Why? Because the elimination of compensation for pain and suffering is associated with a decreased incidence and improved prognosis of whiplash injury. And I'll tell you, personal injury lawyers is growing in Canada also. I know it's a lot in the US, and I consider them, without being offensive, as bloodsuckers. They're the worst thing that could happen to the health of someone, a personal injury lawyer. And I won't even get into the details of it. Next one, fear of not recovering. So, hopelessness is of relevance for the treatment of patients with chronic back pain. So, mark down your fear of not recovering. You circled? Good. If you have no pain, then you just put 0. And we all know the fear avoidance model. Everyone's pretty much presented it. Fear catastrophization leads to avoidance of physical activity, increased disability, low mood, depression, heightened pain experience. Good. Next. Fear of not recovering. There's moderate quality evidence that pain education reduces low back pain related primary care visits more than usual care. So we got the evidence. We're still, question 8. Now, systematic reviews have shown that patients who learn to not fear pain have had better recovery than those who do not receive pain education and continue to passively cope with pain. And so now we got the Cochrane database, 2009, to support that. Hence, we're here at the summit. Every presenter presented how we can possibly give more education. Now, one of the important things, in my humble opinion, is to explain the limitations of radiology. Patients who receive MRI for their low back pain who are made unaware of the results, even after 1 year, have significantly higher self-rated general health. That's why, I don't know, it's been now 5, 6 years ago, I developed a VOMIT poster. The VOMIT acronym stands for Victim of Medical Imaging Technology. And I'm happy to say it's now translated into 8 languages, in Mandarin, in Russian, in Norwegian, and the VOMIT poster, I'm just curious, who here has it in the clinic up? All right, so a few of you raise your hand according. Well, it's free to download the high image file on my website, the APTEI website. Download, email me, and I'll send it to you, the high image. Print it yourself, or I sell it for $20. But I'd rather if you printed it yourself. I don't have copyright on it, anything. I just want it spread. So that's how you find a VOMIT poster. And basically what it says is, cervical spine, when people come to me with degenerative disc disease, I got arthritis in my neck, I say, do you know what percentage of the asymptomatic population has arthritic changes in their neck? I say 98%. 2% of people are freaks of nature. that don't have degenerative changes. People need to know that stuff. And if it's in print, I find it means more. I know we give that education, and all the references are there. I've had a few backlash, very few from this poster. People say, where do you get your facts quote from? And I say, peer-reviewed journals done by radiologists. I don't know who else to get it from. So that's about the only I have. Next, question number 9, low mood depression. Depression is more common in chronic pain patients than healthy controls. Yes, we got systematic reviews, multiple of them to defend that. But the question is chicken or the egg. And look at this reference, pain and depression, the egg or the chicken story revisited. There's growing evidence that depression and pain share genetic factors, biological pathways, and neurotransmitters. The truth is it's both chicken and the egg, meaning you have depression, you're more likely to get chronic pain, and if you have chronic pain long enough, you're going to get depression. All we know is there's an association. So, and I think it should be addressed. Go ahead, answer that question, number 9. Circle it, that's how you answer it. Good. Next, if you're still on question number 9, low-dose antidepressant therapy appears to be beneficial for those with chronic non-cancer pain. Like amitriptyline used to be popular for people with fibromyalgia. So I'm not anti-pharmaceutical interventions for people with depression in any shape of the imagination. We got studies to support that it does help pain and function. Next, exercise is associated with reduction in depressive symptoms among selected adults with arthritis and other rheumatic conditions. I'm a bigger fan of promoting activity because that's in my scope of practice. So again, we got so many meta-analysis and systematic reviews supporting this, that exercise, the challenge is people with depression or low mood, how do you get them motivated to be active again? Hence, this little booklet that you're filling out. All right? Next, comorbidities. Physical and mental health comorbidities are associated with chronicity, low back pain, and healthcare utilization. So go ahead, answer that. Comorbidities. If you have no comorbidities, it's just your knee pain, it's just your neck pain, just your back pain, that's good. But you've got multiple issues, ooh, it's a risk factor. So now what I'd like you to do is calculate your D score, your danger score, and write it at the bottom. Write down all the numbers. Did you do that? We're good. Yeah, you counted? Good. Don't go to the S score yet. We're about to do. So the D score was the danger score, which goes on that side of the apothecary scale. Now let's go to the S score. Question number 1, physical activity. So the available evidence suggests physical activity and exercise is an intervention with few adverse events that may improve pain severity and physical function and consequent quality of life. Again, Cochrane review, database supports physical activity in helping pain. Mark that. What is the level of physical activity that you have? You did it? This is, again, it becomes conversation. It's not meant to be an outcome measures. I don't really care about the number. Good. Next one, family support. Question number 2 is family support reduces the negative impact of chronic conditions. Results indicate that depressive symptoms decrease significantly with strong family and spousal support. Again, I'm just quoting the most recent studies like published in the Psychological Health Medicine. Go ahead, mark that. We keep saying that pain is complex, and I agree. There's no way I can help somebody's chronic pain with feeling their pivum and L4-5 left rotation hypomobility. It's impossible for me to say I can help them with transversus firing. It's far more complex than I ever envisioned. And hence, or to say there's one psychosocial factor that determines how a patient's going to recover. It can't. It's got to be multiple factors and a bit of this, bit of this. So let's continue on. Work satisfaction. That's a guy going to work, and you can say, well, I got Mick Jagger there. So what is about work satisfaction? Satisfaction with one's job may protect against development of chronic pain and disability after acute onset back pain, and alternatively, dissatisfaction may heighten risk of chronicity. Mark your job satisfaction. You guys all better mark 10. Because I certainly mark it 10. I love what I do. Maybe that's a factor. In my 25 years, 6 years I've been going to work as a physical therapist, I've maybe taken, 4 days off work. because I don't know what it would take for me to take a day off work. That's because my wife forced me to. Didn't want me to pass it on. Based on 54 RCTs, there's strong level of evidence to support that low level of job satisfaction is a risk factor for recurrence, chronicity, and non-return to work in low back pain. So we know job satisfaction makes a difference. So when they do studies that they randomly allocate people with non-specific low back pain, half of them get manual therapy, half of them get stabilization exercises. Conclusion is, neither one's any different. None of them ever asked them, what's your level of job satisfaction? To me, that's the most crucial question that determines whether they're going to get better or not. But they don't ask. It's not even part of the studies. When they do studies on which exercise is beneficial, half people get extension exercises, half the people get flexion exercises. To me, those are just stupid studies where they assume that everyone with back pain benefits from flexion, everyone with back pain benefits from extension, and not even asking them about all these other factors. Yes, please. Oh, yes. Okay. So he's saying, and then we try to subgroup them why they got better with various physical factors. It's not physical. All right? Next one. Question number: diet, smoking, alcohol. So what are the studies on that? Several diet and lifestyle factors have been identified as potential risk factors for chronic pelvic pain severity, including smoking status, alcohol consumption, less water intake, and an imbalanced diet. I just took, pelvic pain right now to present. Go ahead, mark that right now. None of these factors have been shown to cure people with chronic pain on their own. None of them, or consistently. But every one of them, I've personally experienced, have had patients, if they address one of them, has completely resolved their pain. But those are anecdotal cases. So every one of them is a potential factor. Some people, it's much bigger than other people. Some people just had to change their diet and their lifestyle, their pain resolved. Other people changed their job, they quit. The day they did that, it resolved. Other people moved away from their mother-in-law. The day that happened, their pain resolved. Satisfaction with healthcare providers. I quote Mick Jagger again. So patient satisfaction with their healthcare providers may confer short-term and long-term clinical benefits for low back pain patients. Go ahead, mark your level of satisfaction. You can put 0 because, 10 if you don't have a healthcare professional because you don't have any pain. But many people are dissatisfied with their healthcare. And the more dissatisfied you are, the less likely you're going to recover. It doesn't matter if it's your physician, your therapist. Time spent outdoors. I like that one. And I don't care if it's in San Diego at beautiful sunny days or at minus 20 degrees in Canada weather. Being outdoors is of benefit. I think it's far more than to do with the vitamin D and the sunshine. Now, there was somebody who presented at once, I remember, it was a vitamin D conference I went to, and they said, the modern human we're the true generation of cavemen in the history of mankind. At no point human beings have ever spent more time indoors than we do right now. Ever. We spend indoors when we go to work, at our house, everything. And once you have in pain, your time spent outdoors is pretty much minimal. But what about this Japanese study? We concluded that the degree of exposure to sunlight may play a crucial role in preventive of joint pain. These findings should encourage patients to set aside some time for staying outdoors in their daily lives. Interesting what, it didn't matter if it was winter or summer. So it doesn't matter. It's just being outdoors. So next, relaxation and mindfulness, which we already not touched on. We went over through. I'm a huge fan of this. Mindfulness meditation has most prominent effect on psychosocial aspects of living with chronic pain, improving associated depression and quality of life. Now, see the reference, it's a systematic review. I didn't say necessarily decrease pain, and that was mentioned also, but it improves quality of life. Our goal as clinicians is not to eliminate pain. Yes, if that happens as a side thing that happens, wonderful. But it's to improve their quality of life. And certainly mindfulness happens to do it. And the vast majority of people in pain don't practice this at all. At all. They don't even know what the word means. Can I have you answer that question? Now, I know we don't have an exact amount that we needed because, this presenter wasn't able to answer it either. I said, if I personally had some kind of chronic pain, I'd do 1 hour, 7 days a week. I devote an hour of my time to do it. Right now, I do 10 minutes, like 5 days a week, personally, just for my own pleasure. But if I had actually persistent pain issues, I'd go for the hour, devote an hour to it. Sleep quality. We all know sleep is important. But sleep problems have a significant impact on recovery for those with low back pain. Clinicians may wish to consider treatment options that can address sleep problems. So I just took the most latest one, a 2018 paper in pain practice. There's no question, there's an association. And I've had a handful of people completely resolve their pain, chronic pain conditions by going to a sleep clinic and having diagnosed with sleep apnea using a CPAP machine. So the only problem with the CPAP machine, compliance rate, really bad. But for the ones that use it and it's effective, it changes their life. It's a factor. Now, on the other side of the coin, I don't want people to become so paranoid, I must sleep well, I must sleep well. If I don't sleep well, I'm never going to get better. That defeats the purpose also. But just appreciating if you're not sleeping because you're on your phone all night or because you're partying all night or whatever it is, it should be addressed. Now, how are the ways to address it? There's numerous books and ideas, and pharmaceutical intervention should absolutely be the last resort. Now, question number 9, life goals and plans. That's the most difficult one. And I do want to spend some time on it. So can you answer that? Now, question number 9. For yourself. Most people will answer low in that, even if you don't have pain. So here's a study. Our findings confirm that a patient-centered goal-setting intervention is a potentially effective intervention for the management of chronic low back pain, showing significant improvements in both quality of life and pain intensity. I really like this study. I liked it so much that I even contacted the author. It's the first study of its kind, believe it or not. It was published in Spine, and it was a small number of patients, I think 20-something, and it wasn't even a randomized controlled trial. And it was published in the journal Spine, and it was done by a physio. And here's an amazing thing. You may say, what, there's no study on goal setting and chronic pain? Not one of them had done what's called patient-led goal setting. They asked the patient, what do you want to achieve? And they saw the physiotherapist once every 2 weeks for 2 months. And they followed them after the 2 months and after 4 months. And they realized the ones that all of them improved dramatically in their pain scores more than any other intervention. They had failed manual therapies. They had failed muscle retraining. But they responded to the goal-setting stuff. Could it be that simple? We just got to ask patients what do they want to achieve and help them achieve it. So now the next part is to do a randomized controlled trials and all that stuff, the typical things that they want to do. So final one, question number 10, fun in life. Sounds simple, but it's extremely important. Now, go ahead and answer that, and I'll read the level of fun in your own life. Mark 10, please. So this was an interesting study done in China. And it was upon completion of a humor therapy program, there were significant decreases in pain and perception of loneliness and significant increases in happiness and life satisfaction for the experimental group, but not for the control group. So they took seniors with chronic pain, and half of them, they put them in the humor therapy group where they did 30 minutes. It was 3 times a week, and the other group didn't do it. And those people had significantly better outcomes in their pain scores. Humor therapy. I'm actually a big fan of laughter yoga. The study's on around, so. Can we do this, please, for a second? Everyone looks too serious right now. 10 seconds of laughter we're going to do. Ready? 1, 2, 3. Loud. Okay. All right, you're good at that. All right. So here's the truth. The brain doesn't know the difference between your real laughter, emotional mood, and people in chronic pain are just not in the mood to laugh for any reason. They're just not. And that's why and of course they socialize less. They even hang out with people less. And so laughter is important, or just smiling, but you don't feel like smiling when you have pain. So calculate your S-score. Go for it. Add the numbers up. and then write it at the bottom. Then I want you to take your S score and your D score, write it on the scale on page number 9. And I'd like you to read page number 9 and 10, which is what patients would read. I know it's repetitive, but read it. Write your numbers in the scale, in the gray boxes. See which one's heavier. Okay. Read page 10 also. Then go back and check mark the ones that you want to change, or you think you can change. Check mark on the box beside it. Going back to the 20 questions. Check mark the box. Maybe one of them, maybe 5 of them. It doesn't matter. Check mark any of the questions in the D or S score that you say, you know what, I wish I was a little bit better in that one. Again, this is patient-led. It's not me telling them. As you may be able to tell, I don't care too much about changing the S score, the stress, because I can't change financial stress or family stress. And our goal isn't to, my goal is just for them to identify, acknowledge that they have this. That's all I want to do right now. We don't want to change things. They just want to accept that it's there, and it could be a contributing factor. But the things that we can change potentially are the S scores. So now that you checked it, I'd like you to go to page number 11. And check mark page number 11, and I want you to briefly write down the stresses. If you had 0 stress, make up something. If you had some mild stress in life, I want you to write it down. Remember, nobody reads this. Just yourself. I don't read my patient's stresses. Just write it down. Page number 11. Just acknowledge. By writing it down, you're acknowledging. Set in as much detail as you can. Some people write again about their mother-in-law. Other people write about workman's compensation. The work stress. This is called writing therapy. And there's actually good evidence to support writing therapy, what you're doing right now. It works far better than talking, it seems like. Okay, look up for a moment. I tell my patients this. I said there's 2 extreme groups of people. There's people who talk about their pain all the time to everyone, their neighbor, their spouse, their people, strangers on the street, they talk about their pain. And there's people who hold it in. They don't talk to anyone about their pain. Which one of them has a better quality of life? Come on, which one? No, there's no difference. The study shows there's no difference. Those who hold it in versus those who tell everyone. In fact, people who talk to everyone about it, other people find them annoying because they're always talking about their pain. But it actually doesn't make a difference. But I tell my patients, you should talk about it to people who actually can help you. Your healthcare providers, me, I want you to tell me everything. I'm just talking about it seems not effective when people talk to everyone about it. You know what is effective though? Writing it down. It seems like when you just talk about it, it just goes into space and disappears. But when you actually physically write it down, it becomes something concrete, and you stare at it, yeah, and I checked off that is a stress thing in my box. Because And don't try to change it. Again, we're not there to change it. We're just there to acknowledge it. Now we're going to go to page number 12, the S. Check off which one of them you could possibly improve. You've already checked it off before. You're going to check it off again. One of them or three of them. Page number 12. Read it and check off the boxes. This is all done in 15 minutes. I just took longer because I'm talking. All right, after you've checked it off, now the most important part of the page, page 13. Again, have your pen ready. Page 13, you may set your goals such as play tennis for 1 hour, walk the dog in a park for 30 minutes, independently go grocery shopping, do an hour of yoga class, cook dinner for family, garden for 15 minutes, anything that motivates you. This is key factor in your recovery. The 3 physical activity goals that I wish to achieve in the next 3 months are write down something. Go ahead, do it right now. And it takes time. It takes effort to figure out what you want to do. And being pain-free can't be one. Get rid of my pain can't be one. Write down cook, 1 hour. Garden, 15 minutes. Wash my dog. Clean the garage. I keep using the word something that motivates you, something that you actually want to achieve. It's not me telling them. They have to come up with it. Okay. Write down 3 things. I want to wait. It's difficult. Now, this is easier said than done. Certainly, I have patients ask him, can you name 3 activities that are important to you that you want to get back into doing? And they said, well, I just want to be pain-free. And I said, all right, if you were pain-free, what would you do? Well, I just want to be my normal self again. Okay, what would your normal self do if you had no pain right now? Well, I just don't want to have this pain anymore. And it's like, So if a person can't come up with an activity, even a single one, that they would like to get back into doing, what do we say they may have? Depression. And that is an uphill battle, unfortunately. I have a lot of difficulty helping my patients with depression. I just can't, because if I can't motivate them to do an activity and the goal is purely to get rid of pain, I can't. I wish I could. It's, how many physical therapists does it take to change a light bulb? 1, but the light bulb would have to want to change. Right? So the person would have to want to change. They would have to want to. If I can't get them to come up with anything, I really can't. I wish I could. So the final page, which is page number 14, and we're done, I'm confident that I can change my DNS scores by, it's the same things that you checked off, by walking more, spending more time outside, going back to the gym, doing 10 minutes of exercise, eating better. Write down something that you wrote down in your physical activity scores. Write it again. It's being redundant. How can you change your DNS scores by? You must have brainstormed something. You're trying to tip the scale. I know most of you, your scale was quite tipped to the safety side, which is great. So you may have a harder time. The next one is, it's important for me to make these small, easy changes because, why is that important to you? Write it down, because you can write down, I want to be pain-free. I'm okay with that. Because I want to feel better. I want to enjoy life more. Make it as vague, as accurate as you want. Why is it important to you? Because I need to be healthy again. You can write 1 thing, 2 things, 3 things. This is all part of motivational interviewing, except it's put in paper. Why is it important to you? Why did you even put those activities in there? I want them to tell me. Next one, now that I've committed to making these changes, I feel, how does it make you feel if these changes were to happen? Which they will probably. You'll get closer to those goals. How does that make you feel? Write it down. It would make me feel good. Fine, right, good. I feel great. I feel happy. I feel optimistic. That's actually the most important word I want them to walk out after seeing me. I feel optimistic again about my recovery. And read the last sentence. And that's the end of it. That was it. I've given you a sheet of paper also. Go to the sheet of paper. You can see it. It's pretty much, that is done in 5 minutes. And the back page is the score. Again, it's not a questionnaire that's supposed to be calculated. It's a questionnaire, health questionnaire, that helps you figure out your patient, what they want to talk about. In the areas that they score 9 or 10 in, you may say, would you like to expand on that? And how I can help you. And understanding that safety and S score is people probably don't defend themselves. I didn't tell them the pain's in your head, the brain. They can understand that. Stress increases pain. Who's going to debate that? They know that already. So let's go through this. Which side of the apothecary scale does your brain judge to be dominant, or safety or S side? When the scale favors the safety side, the brain produces powerful chemicals, morphine, serotonin. I repeat everything twice. However, when the scale leans towards the danger side, the brain stops producing these powerful chemicals. Your goal must be to increase your overall safety score and lessen your danger score. Simple, right? The goal of this exercise is not to eliminate your stresses in life, but to simply acknowledge and be aware of them. I wish I could eliminate people's stresses, but I don't seem to be able to. So go ahead, look back at the DNS questions and decide which one of the factors you would like to address and positively change, and check the box. Again, they check the box because I want them to determine that. The goal of rehab is to address the factors you are most motivated to change and are confident that you can improve in. Grab a blank sheet of paper. You don't need this book. And by the way, if you want the Pain Truth book, I have the ebook version. Every one of you, I'll send it to you for free, complimentary. It's there, print it out, as many copies as you want. I don't have copyrights for people to not have it. In fact, disseminated. I have it in French and English because I'm in Canada. So I can send it to Rajam, or I'll give you my email at the end. Send me an email, and I send you the ebook. Distribute it as much as you want. Call to action. Then you tell them what you maybe socialize, have coffee with friends again, go out for a walk the dog, practice mindfulness meditation, eat an apple, have 3 fruits and maybe 2 servings of vegetables a day. Listen to music, relax, cook again, home meal food. Maybe change doctors, see somebody else that you would trust in again. Get back to doing your physical house chores that you wanted to do. Look for a new job. That's the guy looking for a new job. Maybe put your finances in order. See somebody about your finances. Start an exercise program. And it doesn't matter what it is. It can be yoga, Tai Chi, but it has to be something that you enjoy. Aqua fitness. And read materials that are conducive to your knowledge of pain. And we all know of websites and whatever we give them, and stop reading materials on websites that are trying to sell you something. In the Pain Truth program, there's not a single lotion, potion thing that I try to sell to patients. There's nothing to sell other than information and everything that they can do on their own. It's all about empowering them, and we all know that. Why? Recall the 2016 study on patient-centered goals. Our findings confirm that a patient-centered goal-setting intervention is a potentially effective intervention for the management of chronic back pain, showing significant improvements in both quality of life and pain intensity, which is remarkable. They had no other intervention other than getting them to set goals, and the only thing the physical therapist did was every 2 weeks see them for 1 hour and set small goals. What do you want to be able to do? Oh, why don't you try to do this then? If you want to clean the whole house, then clean 1 room this week. That's what I like you to do. Simple stuff. You want to garden? Just pull weeds out for 10 minutes instead of doing a whole hour of gardening. And get them to choose their own goal. Any one of this stuff, whether it's an activity goal. And I agree, I don't like to say you must exercise or you will never get better. But I don't think there's much to, because you don't have to exercise to get better. You can get better without going to the gym or doing exercises. But I don't think you can get better without physical activity. We all must encourage physical activity, and it's irrelevant what it is. So without clear, meaningful, exciting goals, the brain will find it hard to get motivated to do anything, including just getting out of bed. I apologize for quoting myself. I don't know who else to quote. So In the book. That includes cooking, walking, washing the dog, going back to your job as a mechanic, even if it's part-time. Setting small, achievable, specific functional goals is not optional. It's essential for recovery from a persistent pain state. It's not optional to get better. There's no other choice. If you don't have a goal, the chances are quite low that you're going to wake up one morning and say, hey, I'm pain-free today. I can get back to my hour of yoga classes again. I'm pain-free today. I can go back to my work again as a tile layer, whatever it is. Now, in summary, explain the apothecary scale. Safety side, have them complete the DNS questions. Have them check which ones they're motivated and confident they can change. Have them write down a sheet of paper, 3 actions they wish to take to achieve their goals, and let them choose their goals. Patient-led goal setting is potential for improving disability, pain, quality of life, self-efficacy, and fear avoidance beliefs. And thank you. That's it. Now, again, write down my email. I'll send you the Pain Truth book, the pamphlet, the PDF thing, whatever you want. Again, my goal is to disseminate them. And the vomit poster. And print it yourself, or you can order it on my website. I prefer if you printed it yourself. Go ahead.
I hate to say it, but we actually we don't have time to do a Q&A session. We do have time, however, for a 10-minute break. So we will be back. Our next presenter is going to get started 4:15.
Why do they need a break? Why do they need a break?
Well, we at least need to give them a few minutes to get here. So if you guys want to roll through, we can do Q&A session until our next presenter is ready to go. Oh, hell yeah, then. Yeah. All right, then. Okay. Well, in that case, let's start off with some questions. And I need I'll need a volunteer to let me know when our next presenter gets here.
Here.
He's here. He is here.
He's here.
Okay.
You're supposed to. Yeah.
All right. Well.
Do you have a question?
I'll let you know when I get here.
All right.
You got to plug in your stuff.
While he's getting all set up, though, we can still take like maybe 2 questions. So can I see any questions? All right. Question right there in the back, please.
What do you say to a patient if they ask, why can't my goal be to be pain-free?
Because I say physical activity is what we're aiming for. Because you can have pain still and increase your physical activity. And I draw this circle that I learned last year at the summit. I draw a circle, and I put inside that circle, this is your pain. And I draw a little circle outside of that pain. It says, right now your pain, and I say that's your life, the outside circle. Right now your pain encompasses most of your life. What our goal is, obviously other healthcare professionals, we haven't been able to decrease your pain, but we can increase, I draw a bigger circle outside the pain. Our goal is to increase your life despite this pain. And as your life increases, the meaning of the pain becomes less. And I find that to be a good analogy to give. That's why.
And we had another question a little closer towards the front.
So do you have any recommendations or ninja skills at getting patients who don't want to make the effort to change? They just want you to fix them.
Yes.
And they don't want to hear any of this stuff about pain science and how they need to, they need to be the ones to make the changes. They only want you to fix them. What do you say to those patients to help motivate them?
I lose them as patients.
Okay.
Yeah,
right.
I do. I try to. I'm a manual therapist. I prescribe exercises, and I try to find specific orthopedic conditions to treat. And I try it, and I try to rule out red flags. And once I've done that, and I've seen them a handful of sessions, and I made little change, I said, I've tried it, and it hasn't worked. So now we've got to take a different approach. And I tell them, I quote Einstein a lot. I said, the definition of insanity is doing the same thing, expecting different results. Would you like us to try a different approach? And if they don't buy into it, I'm going to say, yeah, at least half of my patients don't buy into it. I guess I'm not a good enough salesman. I try to. And I wish I could cure all my patients with chronic pain. That would be false. But I can honestly, the ones that follow through with the whole Pain Truth program, pretty much 100% of them have improvement in the quality of life. Again, but it's a small fraction of people to actually follow through. The ones that do well. Good.
I think we're going to have time for one more question.
Good.
Did we have? I saw another hand, but it went back down again. Okay.
He's